Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have a very interesting and complex case here, guys. So I'm going to just give you the backstory. This patient last visited myself in December 2022, and they have a long history of a tympanic perforation in their right ear. You'll see that in a moment. It's a subtotal perforation. And the ENT are fully aware of this perforation, so it's just managing it. Occasionally it gets wet. It's a bit wet at the moment around the rim and on the middle ear mucosa. You can see there, slightly damp. So the patient has got some non-ototoxic antibiotic drops. So these drops are safe to use in the presence of a perforation. Many of the antibiotics used for ear infections, topical ones, they cannot be used if you've got a perforation because they can enter the middle ear cleft and get absorbed into the cochlea, which is the organ of hearing, via the oval and round window, which can then cause irreversible damage to the sensory hair cells within the cochlea. And these hair cells, in response to sound waves, they shear side to side and they produce an electrochemical response, and these electrochemical signals are then sent to the brain, to the auditory cortex, where it's then interpreted into sound. So this ear I wasn't too concerned about because it's a chronic problem, ENT are fully aware. But back in December 2022, in their left ear, which you're going to see in a moment, they had a very severe posterior retraction of the eardrum to the back section, so around 3 o'clock, if you're looking at the eardrum. In fact, it was so severely retracted that the eardrum was making contact with the promontory, which is part of the cochlea, the organ of hearing, the outer bony wall. So we're looking about 4 or 5 millimeters past the eardrum here, guys. It was that much retracted. At that stage, it wasn't adhesive. It wasn't stuck to the promontory. So we'll call that a grade 3 Sadé retraction. I hope I pronounced that correctly, Sadé. If it was adherence, if it was stuck to the promontory, then it would be a grade 4. So it was a grade 3 at the time. There was no infection though. It was self-cleansing, there's no keratin, and the patient did advise they saw ENT and they were discharged. Sometimes in those cases, again, you manage it. There's no surgery, it's not always possible. As long as there's no dead skin migrating into that retraction pocket, it's just a case of monitoring it. So that was the last time I saw the patient. Now, this patient has also got hearing aids on the NHS, and they went yesterday to get the hearing aids serviced. And when they attended, they advised that the audiologist mentioned that the right ear was blocked, which there was some occluding wax and keratin. And what I'm doing now, this is the tedious bit, I'm trying to remove a lot of this macerated dead skin, this keratin. It's migrated towards the entrance, but it's not shed, it's not become desquamous. So these, typically, all this skin that I'm peeling away, when it migrates and reaches the entrance of the ear canal, the individual skin cells, they detach and they flake away as individual skin cells, a bit like desiccated coconut, for example. Here, all these individual skin cells are still attached to one another. So I'm trying to peel this away, and because the ear is warm and damp because of the way of the hearing aids, they got perforation. It's very difficult consistency. So there is going to be a bit left. So don't give me a hard time over it. It's very delicate what we're doing here. You're seeing a blown up version of this. This patient's ear canal is very narrow. I'm using a fine end here, probably looking a diameter of less than 0.5 centimeter. The height probably about 8 mil. And you can see the skin is very dry. It's dehydrated. So some of it's really gooey and soft like this. Some of it's a bit more crusted. So already I'm really, really pleased. We can see the eardrum. The patient can use their non-ototoxic antibiotic drops. Now, they went to get the hearing aid service. Now, I'm going to be very frank and honest here. I'm very disappointed by the treatment this patient got. They have got a behind the ear hearing aid, what we call a BTE, and it's connected to a custom ear mold that fills up the outer ear. And there's a tubing that goes from the hearing aid through the mold, and that tube transfers all the sound energy from the hearing aid that it's amplifying through the mold into the ear. Now, this patient gets a lot of condensation, a lot of moisture and sweat and humidity in the ear, hence why you've got all this macerated skin. And they normally have a special tubing, it's called an anti-condensation or stay-dry tubing. But when the patient attended, they said they couldn't hear after having the hearing aid serviced the day before. Immediately, I could see the tubing was the wrong one. There was moisture in the tubing, so I changed the tubing for the patient. But these things shouldn't. This is a patient really struggling with their hearing. So a little thing like getting the wrong tubing, which shouldn't be the case. This patient always has this tubing fitted, has really affected the patient and their hearing. The left side, they were told that the left side was clear. But you're going to see it in a moment, guys. This left ear, I've requested an urgent ENT referral because I suspect they've got an active cholesteatoma forming, a middle ear cholesteatoma, which I'll describe in more detail as we go along in this video. So there's a bit left there, guys. It's just a bit uncomfortable for the patient, so I'm going to leave that. I'm happy otherwise. So we're just mopping up a bit here, just at the cartilaginous portion, but from where this patient came in and how I finished, it's much better. Now, you can see clearly there's something's not right with this ear. It's a lot of damp, dead skin in there. There's some granulation tissue on the posterior canal wall. And this is where it gets a bit tricky sometimes, because the patient's got full faith in myself, because I've seen them several times before, but they were under the impression that this ear was clear. And there was a bit of an opening at the top, so technically the patient may have not felt this have affected their hearing, but they did say it was a bit damp and squelchy in there, and you can see why. And already you can see the humidity, the increased humidity is causing condensation of the tip of the endoscope. This is really tricky, guys, to remove, because you've got all this dead damp skin that I'm peeling away off the canal wall. So we're on the bony part, and we just got to avoid contact with the bony part of the ear, otherwise it's going to be really, really uncomfortable. But as I clear this up, at the moment you're not going to see it, you're just seeing all this debris and keratinous damp skin that again hasn't, it's migrating but it hasn't shed. It's just sitting on the surface. So once I remove this, you're going to see the back section of the eardrum again. So it's the posterior part, more so the posterior superior quadrant, which is probably for ENT the most important part when you examine the ear, because that's the site of a potential cholesteatoma, which I'll describe in a moment. The reason why the posterior superior quadrant is a very prominent site for buildup of a cholesteatoma is that unlike the rest of the pars tensa, which is the main body of the eardrum, the middle layer, the lamina propria, which I discussed yesterday in a video, where you've got all these organized fibrous collagen connective tissue, both radially and concentrically, and it gives the eardrum its rigid structure. In the posterior superior part of the eardrum, the fibrous tissue in the middle layer of the eardrum, so the eardrum has it's a 3-ply layer, the fibrous tissue is not arranged in that very rigid, unorganized structure. In fact, it's more arranged like the pars flaccida, the top portion of the eardrum, which does have this middle fibrous layer of connective collagen tissue, but it's not organized, it's loosely dispersed, which doesn't make the pars flaccida any thinner. In fact, it's thicker, but it becomes more elastic. So the posterior superior part of the eardrum has a similar fibrous arrangement as the top part of the eardrum, the pars flaccida, which makes that part of the eardrum and the pars flaccida very prone to retractions if you've got negative middle ear pressure. So what's negative middle ear pressure? We want the air pressure in the middle ear cleft, which is the cavity behind the eardrum, to be equal to the atmospheric pressure, so the air pressure in the ear canal. When the eardrum has equal pressure either side of it, that's when the eardrum is most mobile and most compliant, and that's when you hear the best. So to equalize the air pressure in the middle ear, we all have an orifice called the eustachian tube. It's about 36 millimeters long. Where it opens in the middle ear cleft, it's around 3 or 4 millimeters in diameter, and then it and that section is the bony part of the eustachian tube. And then it travels down to the back of the nose, the nasopharynx. And at that section, it's around 8 to 9 millimeters opening. And that eustachian tube, where it connects to the back of the nose, is actually shut in normal resting state. So as I'm talking to you now, my eustachian tube should be shut, and it's shut for a good reason. It prevents upper respiratory tract infections travelling up the back of your nose and throat, up the eustachian tube and infecting the middle ear. So by being closed, it's protecting the middle ear. But it also prevents you from hearing your internal respiratory sounds and your own voice. Otherwise, if that eustachian tube was permanently open, and we call that patulous eustachian tubes, there is a condition where it's permanently open. When you talk or when you breathe, your breath travels up your nose, as does your voice, and it vibrates the inside of the eardrum. Normally, when you talk, your voice gets projected out in front of you. It travels into your ear canal and it hits the surface, the external surface of the eardrum. But if the eustachian tube is open, not only are you hearing yourself in the manner I've just described, but your voice travels up your eardrum and hits the underside up your nose. So you're hearing your voice twice, so you get a mismatch of your own voice. And people with patulous eustachian tube report of a muffled voice, and they can hear themselves also breathe. And the eardrum actually moves backwards and forwards in line with their breath. So that's why the eustachian tube is normally shut. But during brief moments of the course of the day when you swallow, yawn or chew, I think they've estimated it to be around 4 or 5 times a minute, the eustachian tube temporarily opens. The muscles either side of the eustachian tube, I'm going to come back to that, guys, because here now we're right on the eardrum. This is where the eardrum is retracted. You can see the ring just below where I am, and it's so severely retracted. It's, as I said, a grade 3 Sadé retraction. So it's on the promontory. I don't think it's adhered. I don't think it's stuck. I can't see the incus, the middle ear, the second of the 3 bones. So that looks like it's been eroded. And all this is dead skin, guys. So this skin should be migrating out of the ear canal. But because the eardrum is so severely sucked in, this skin that's migrating off the eardrum, because at the center of the eardrum, the umbo region, that's where that's the site where all the outer skin cells are formed and made in the ear canal, and they project outwards from the center of the eardrum radially, and then they line the ear canal. And as that skin ages, it further migrates, and then it sheds near the entrance of the ear canal into little flakes, and then it mixes with the sebum, the lipid oily secretion that we also found on our scalp, which is secreted on the outer third of the ear, and it also mixes with the oily sweats secreted by the ceruminous glands to form earwax. But here, because this eardrum is so severely retracted, it's buckled inwards, and I think it's sucked in so much that it's actually probably at the cusp of the antrum of the mastoid bone, which I'll try and describe. I've got 5 or 6 minutes. The skin is just invading inwards, sort of outwards, and this skin, it's formed into a cyst, and when it forms into a cyst, it not only compresses against the middle ear structures, and also it can go upwards towards the brain, guys. So this potentially, a cholesteatoma, can be fatal because it can cause a dehiscence of the tegmen tympani, which is the thin bone that separates the skull base to the middle ear. So it can erode that just by pure force sometimes, but also the squamous keratinous skin in this skin cyst called a cholesteatoma, they release harmful proteolytic enzymes, which basically just start chewing away at all any flesh or any skin. Can cause ulceration, any of the bones. And here I'm just at the perimeter now. I don't want to go any further than this, guys. This is where ENT need to get involved. And there's a bit of dead skin actually on that eardrum, but that's right up against, as I said, it's sucked in. And if I attempt to remove that, the middle ear is a very complex area, guys. You've got the facial nerve, the 7th cranial nerve. So if we do damage to that, this patient can have a severed facial nerve. They can develop Bell's palsy, so a droopiness of one side of the face. I don't know if the stapes bone is at all intact as well. I think I can just see part of the stapes bone there, but I don't want to be bumping into these middle ear structures, and I certainly don't want to be bumping into the oval window, which is the gateway to the organ of hearing. It's where the last of the three bones, the stapes bone, connects to, or indeed the round window. There's also some blood vessels in there, which more at the base of the middle ear, so inferiorly. So we don't want to mess around in there. What I'm trying to do is remove as much of this keratinous tissue. So this tissue, this skin, it's unshed skin. It's the outer layer of skin that also lines the inner two-thirds of the ear canal. And you're going to see a good view right at the end when I get the endoscope really in and we look to the right, and you can see the eardrum looks like it's sucked into the mastoid region. So what's the mastoid? Now, the bone that encompasses the ear canal, it's called the temporal bone, and it's regarded as one of the strongest bones in the body. I think second to the femur, if I'm correct. Part of the temporal bone is the mastoid bone. It's the bone directly behind the ear canal, and the bone behind the ear canal, the mastoid bone, it's kind of got a honeycomb structure. So it's air-filled and it's porous, so it can absorb infection. And if we go through the eardrum and turn a sharp right, 90-degree right, that's the entrance to the mastoid bone. There's actually an opening there, and it's called the antrum to the mastoid antrum. And then if you go through that antrum and turn sharply right again, 90 degrees, that is the mastoid bone. And the eardrum, it can get so sucked inwards that the eardrum, remember the eardrum is very elastic, especially the posterior superior region and the pars flaccid at the top part, because I mentioned before, it doesn't have those organized concentric and radially aligned fibrous tissue. So it makes it very elastic. And when it's sucked in, it's almost like cling film. It gets pulled inwards, and this eardrum potentially can be sucked into that region. And then if it's sucked into that region, you've got all this cholesteatoma, all this dead skin growing into the mastoid bone. It can invade the mastoid bone. It can lead to what we call mastoiditis, an infection of the mastoid bone. And again, that can be very dangerous, guys. If left untreated, it can go upwards to the skull base, cause meningitis or brain abscess. So it can be potentially very fatal. It can be fatal. There's no two ways about that. But what we don't know is, because we can't see in there, so this patient will need to have a CT scan, is that part of the eardrum may be perforated. This cholesteatoma may have chewed up with all those proteolytic enzymes through the sheer pressure of the skin cyst. It's chewed up that area, and then it's invading all that space, going upwards. So written urgently to the doctor. Now, when this patient saw ENT last time, there was none of this. It was just a retraction. It was dry. There was no skin formation. This all happened since. So we just an urgent letter to the GP, asking them to refer to ENT urgently. In the worst case scenario, I've asked this patient to go see a private ENT because we don't want to leave this in the ear too long now. You can, guys, again, you're going to see the skin is very cracked and dried around the ear canal. It's not going to be picture perfect. So you can see the eardrum there. You can see some squams of skin. So some unshed skin on the eardrum itself. That's staying there. It's not migrating. We're not going to get really last speck out. It's what we've done here. I found it very complicated and difficult, if truth be told. So I'm just mopping up all this flaky, dry skin that I can without causing any discomfort to the patient. So I've just angled the finer in such a way that I'm gliding, so the patient's feeling very minimal contact actually. And because we know the curvature of the ear canal, when you work in a patient, when you're experienced with ears, you can know the contours. So when you're gliding this, you're going alongside the shape of the ear canal. So there's a bit of soft skin just on the antrum, the opposite part, where we're more focused on the posterior superior part where the cholesteatoma potentially is. At the roof, I did try and get that slightly uncomfortable with the patient. I'm not concerned by that, guys. So I hope you enjoyed that video. Take care, keep well, and speak soon. Bye.